I'm Mary Jacobson. I'm the moderator of this session. Dr. Chueh is one of my colleagues in the Department of Obstetrics and Gynecology at Stanford, and she did a fellowship in maternal fetal medicine. And her research interest and her area of expertise is in prenatal diagnoses as well as diagnostic procedures. So today she's going to talk about prenatal diagnosis, view from the womb.
Thank you for having me today. I thought in the 25 minutes that we have that I would go through some of the things that you might be hearing about at your first visit or when you get close to thinking about having a pregnancy. Okay. So there are a number of choices out there these days with prenatal diagnosis, and there's a huge number. It gets very confusing. I'm going to try and sort that out for you. This is the most common form of genetic anomaly. It's Down syndrome, and as you can tell, there's a specific look about it that you can sometimes recognize children on the street. It's common because it is a sporadic event that happens as the oocytes age, and they're characterized by certain facial features, upslanted eyes, downturned mouth, single palmar crease, clinodactyly, which is where the fifth finger curves in, and this gap between the first and second toe. Now all those things are not a problem, but the main thing is that these have 100% of Down syndrome babies have some sort of mental issue. So what can you do to find out whether your pregnancy has Down syndrome? Well, the first thing is a diagnostic test, which is something that will actually tell you the answer. And there's two ways of getting that answer. One is through CVS, which is short for chorionic VILLUS sampling, performed between 10 and 14 weeks. And then amniocentesis, which is done a little later, between 15 and 20 weeks of pregnancy. The first amniocentesis was done in 1877, which is something I didn't know until I started researching. And it was done in the third trimester. It was done for polyhydramnios, which means too much fluid in the abdomen or in the uterus, and it was not done with any ultrasound guidance. Fortunately, that one went well. A little bit later, they had ultrasound guidance, and I always like this picture because this picture of the ultrasound is very different from what you'll see when you come in and have an amniocentesis. So ultrasound look a lot sleeker these days, and the modern day uses this real time where we can actually watch the needle going in, so we can watch the baby and the needle and exactly where everybody is, giving us a very low risk of complications. So here's a picture of the baby's hand, as you can see, with the fingers, and the needle's right next to it. And we can be as close as, a tenth of a centimeter and be totally fine because we know exactly where we are. So the earlier diagnostic test is chorionic VILLUS sampling, and this is done between 10 and 14 weeks gestation. And it can be done transcervically, which is going through the cervix. And on the left side of the screen, you'll see the white line, which is the catheter, and that's threaded through the cervix, just like you were having a pelvic exam and a pap smear. We thread a very thin catheter through, and we're able to image it simultaneously using an ultrasound transducer, which is demonstrated on the right. Having done that, we pick out a little bit of tissue, and that's what we analyze. This is transabdominal CVS, which is done through the abdomen. And again, we use the ultrasound to guide our needle, and here you can see on the left side the picture of the needle as it's going into the chorionic villi. The chorionic villi is basically the name of the tissue that becomes the placenta, and that tells us information about the fetus. This is what they look like in a petri dish. When we get the tissue, we always look under a microscope to make sure we actually got the villi and not some maternal tissue, which would confuse the results. So what is the risk of amniocentesis and the risk of CVS? In the 1980s, CVS was thought to have a higher loss rate than amniocentesis, about 1% versus a 0.5%. But more recent studies show that CVS is actually no more likely than amniocentesis to cause miscarriage when performed by an experienced provider. And we're talking about several thousands. So, who should have diagnostic testing? Should you? In the past, women over age 35 were advised to have diagnostic testing, and the reason for that, I think, is because at age 35, your risk of chromosome anomaly is about 1 in 150, which now is slightly higher than your risk of the procedure, which in the past was quoted as 1 in 200. However, 80% of Down syndrome cases occur in women under age 35, and more women are having children past age 35. So how do we solve this problem? Do we do an amniocentesis on everyone? Our American College of OBGYN recommendations now say that maternal age of 35 years alone should not be used as the threshold to determine who's offered screening versus who's offered invasive testing. So invasive diagnostic testing for aneuploidy, which is chromosome abnormalities, should be available to all women regardless of maternal age. Well, now, does that mean that everyone should have an amniocentesis? Well, I think the advantages are they definitely give you an answer, yes or no, do you have Down syndrome? It's usually an invasive procedure, but it is associated with a risk for miscarriage. So what we tell patients is that you have choices regarding genetic testing, and diagnostic testing carries a risk. And your age is only one factor amongst many others that influence your risk for genetic defects. So what we recommend is that you look at these other factors to personalize your risk. So how do we find your individual risk? Well, screening is one thing we do on everyone. And screening is basically a technique of looking to see who is at high risk for whatever your outcome is. And in this case, it would be for aneuploidy. So currently, we have screening both performed in the first trimester between 10 and 14 weeks, and also in the second trimester between 15 and 21 weeks. The first trimester involves a measurement of the back of the neck, called a nuchal translucency. Nuchal means neck. And then a blood draw with 2 proteins at about the same time. And here's a couple of things about the NT. It's basically a measurement of the thickness of fluid behind the fetal neck. It's a marker, not an anomaly itself. So in other words, it's not something that will actually cause the baby a problem, but it may tell us if the baby has Down syndrome or some other anomaly. So here's an example of a normal nuchal translucency, a normal NT. Behind the neck, that probably measures about 1.8, I would guess, if we were to do that. Here's an example of an abnormal NT, and you can see how much wider that is. The black area is the fluid behind the back of the neck. So the increased NT picks up Down syndrome and other chromosome abnormalities such as trisomy 18 and Turner syndrome. Also, fetal cardiac defects can be picked up with this, and other fetal disorders that have altered lymphatic flow, such as abdominal wall defects, umbilical, diaphragmatic hernia, and some other odd fetal movement syndromes. So the procedure is you draw the blood in your obstetrician's office between 10 weeks and 13 weeks, 6 days. And then the best time to do it, I recommend, is somewhere in the middle, but certainly a week before your NT. So your NT is the ultrasound, and if you do your blood work a week before, then they'll have the results of the blood, and when you go in to have your NT, they can put all that information together, and that same day they'll give you the results. So the only reason I say that in the middle, or not exactly as soon as you turn 10 weeks, some people are so anxious and they want to do things as soon as possible, is that if you draw your blood too early, then it becomes invalid. So here's an example where a patient draws her blood as soon as she's 10 weeks, or what she thinks is 10 weeks. 2 weeks later, she has her NT, but instead of measuring 12 weeks like she thinks she could measure. She measures 11 weeks, 6 days. And this can happen just by measurement variation. You know, she probably still is 12 weeks, but our measurement only gives us 11 weeks, 6 days. So that would place her at 9 weeks, 6 days when she had her blood drawn. And according to the state, that's too early and you cannot interpret it. So then she would have to go back and draw her blood. So I always like to do it in the middle, somewhere maybe 11 weeks, 12 weeks, depending on when your NT is. If your NT is scheduled at 12 weeks, then you would do it 11 weeks and so on. So the measurement is very important because there's a specific measurement of the crown rump length here, which is shown. That is necessary to interpret the NT. So here's one patient who has had her blood done at 10 weeks, 4 days, which is perfectly fine, right in the middle of the window. So she eagerly schedules her NT for 1 week later at 11 weeks, 4 days. But her fetus only measures 44 millimeters. And again, that could be variation because most fetuses at 11 weeks, 4 days would measure 45 millimeters or greater. But because it's 44, we can't technically put in a measurement for the NT. Even if we could see it, we could measure it, it still doesn't count in the computer system. So she would have to reschedule her NT until her fetus was a little bit bigger. Here's an example of the report you get. I'm not going to go through that because you can't read it. But one thing to mention is people are always asking me in this previous report, it tells you what the risk is. And here in this one report says your syndrome or your Down syndrome risk is 1 in 2,600. And they say, well, is that a good number or is that not a good number? Is that average? So there's two ways of looking at it. One, you can say, well, 1 in 2,000 is a relatively low risk based on basic probability. And here's like a chart here which says, if your chances of something happening is 1 in 1, that's very high. Obviously, that's 100%. If it's 1 in 10, that's 10%. That's still pretty high. But 1 in 1,000, you're starting to think, well, that's a pretty low risk. That's much lower than 1%. And so you can think of numbers that are 1 in 1,000 as being pretty unlikely to happen and a very good number. The state, however, uses 1 in 100 as being high risk. So if your risk is 1 in 100 or higher, then you'd be offered a CVS or an amniocentesis, and they would pay for it. However, if it's lower than 1 in 100, they think you should do other things, and I'll go over that. Another way to look at it is, how is this risk compared to my age? And here's another report that we used to use when we used a private lab. And here it says the Down syndrome risk is 1 in 2,541. So is that good or bad? Well, according to the absolute way, it is good. But you can also look at it as this, where the top line shows a Down syndrome risk, and this patient is 38. And her risk before the screen was this much. And now, or before she had 38-year-old risk. And now she has the risk of a 20-year-old. And that is really easy to understand, and most people like to hear that they are like a 20-year-old. So that's one way of thinking about it. They're very happy when they get that. So the state now has this full integrated screen, which incorporates the first and second trimester. And I already mentioned the first trimester screen has a risk of 1 in 100. The state pays for the diagnostic testing. And with that, we pick up about 75% of Down syndrome, with about a 2.5% false positive rate. If your risk is low in the first trimester, in other words, less than 1 in 100, then you go on to second trimester screen, which is done between 15 and 20 weeks. And that is blood test. It's also covered by the state. And if your risk overall comes out to be greater than 1 in 200, then you'll be offered a diagnostic test, which in this case would be amniocentesis by that time. And together, they pick up 90% of Down syndrome risk, which is really, really good, with about a 4.6% false positive risk. So should one act after the first trimester screen? Here's an example of a 40-year-old who, if she'd gone with the initial risk profile of I'm over 35, I should have an amnio, she would have had an amnio with a risk of about 1 in 200 for miscarriage. But she does the screen. Her first trimester screen comes out 1 in 140, which is not terrifically low. It's better than her age, and it is certainly negative according to the risk of the state's risk, because they say 1 in 100 or higher she would qualify for a diagnostic test. So she's a little unsure what to make of that. But after thinking about it and counseling, she decides to go ahead and have their second trimester screen and then wait for the final result. So her second trimester screen integrated into her first now shows a Down syndrome risk of 1 in 22,000. This is an actual case. So just to show you how the information is only preliminary in the first trimester, and that you shouldn't freak out about the number because that's only a preliminary thing and only picks up about 75% anyway, and you should wait until you have all the information in most cases. For those who don't get to their OB in time to get the nuchal translucency, let's say they didn't know they were pregnant until about 16 weeks, the second trimester for those who don't have the nuchal translucency, let's say they don't have the money to go and get an ultrasound, or the insurance doesn't cover it, which is very few now because Medi-Cal actually covers this now. You can do blood tests and then wait until second trimester and get the blood test done. And even with just blood testing alone, you get an 85% detection rate. So we're not discriminating against people who can or cannot have an ultrasound. 85% is really pretty close to 90%. For those who miss the first trimester screen, they come too late, then you would do the second trimester screen, which is 4 analytes. And just based on the second trimester, you get an 80% detection rate for trisomy 21, which is not as good as the 90, but not bad for having missed the first trimester. 67% detection rate for trisomy 18, with about a 5% false positive rate. If any of you have any questions about what false positive rate means, I can explain that afterwards. So let's spend the remainder on the future of prenatal diagnosis, because this is where everybody's interested in. So for probably 20 years now or longer, since I was a fellow, it's been a long time, we've been looking for the fetal cell in maternal circulation. And I think of this as the holy grail, because this was my fellow project and was extremely frustrating. Little did I know that it was really an impossible task at the time. But anyway, I tried to find the fetal cell, and there were all kinds of difficult things. And what we were doing, we were looking for the fetal nucleated red blood cell. And we couldn't do it. Today, there are more and more techniques available with DNA and fancy science, and now they're looking at cell-free DNA. And I'll go over what some of these offer and why they're advantages to each. So eventually, with the whole project of intact fetal cells, this paper came out in 2003 in The Lancet. And it basically, all the authors I knew, because I had seen them over and over and during the time that I was a fellow, they were all working on the same thing. And they're all basically authors on this project. And they said at the bottom, we believe that recovery of these cells is difficult and not clinically practical. And on the left, you'll see these plots of what we were trying to evaluate as what was fetal, what was maternal. And you can see they were very messy. Now, there might be more stuff coming out. I've just met somebody who says that they have the intact fetal cell in this very room. But we have yet to see, if our better techniques today are able to do that. So then, the interest shifted to cell-free fetal DNA because the intact fetal cell had problems with cells from previous pregnancy. It turned out that, if you had a baby before, some of the cells from the previous pregnancies were still floating around 6 years later. Now we know that cell-free DNA has a very short half-life, so it cannot be confused with the previous pregnancy. It's readily detected in patient plasma. It's detected as early as 7 weeks gestation, according to a lot of studies. Its concentration ranges between 3 to 6%, which is amazing compared to what we were working with before, and it increases with gestational age, and it's not detected 48 hours postpartum. So there have already been some studies that show that they can pick up cell-free DNA and do diagnosis on some X-linked diseases because you can tell the difference between whether it's a boy or girl pretty easily. So Duchenne's would be one example of an X-linked disease, and affected individuals are male, and females are carriers, but they're not affected. So therefore, if you could tell a patient whether it was a female or a male, they would know. So if it was a female, then you were safe. So that's one way, one thing they've already used this test for. Another is on maternal blood, is looking to see whether the baby has Rh positive, Rh negative blood type, and this is important for women. About 5% of women are Rh negative, and because 95% of the population is Rh positive, their partners are probably Rh positive, and their fetuses have a chance of being Rh positive and therefore incompatible in utero. So if you were able to demonstrate the fetus as having Rh negative type, then everything would be fine. You wouldn't have to worry. And the blood test has been used to diagnose some of these cases too. So it does show some promise. But are we really ready to go from amniocentesis to a blood test? And so here in 2008, Stanford cooperated with a scientific lab on campus that were looking at non-invasive prenatal diagnosis, which used a lot of, I'm not going to go through the study design, but used a lot of fancy science basically to look at sequences on a certain chromosome, say trisomy 21, which would be Down syndrome, or on the 21st chromosome, and compare it to a normal. And what you would get after you did all these studies is you would get certain fragments of DNA, and you'd plot it out, and you plot it against which chromosome, and then look and see if any of them looked out of range. So here you can see in red, because you can see easily because they put it in red, is that on the chromosome 21, there seems to be a higher ratio of 21 chromosome fragments than the other ones, which are 2 copies. So it's suspicious that there's more chromosome 21 in that particular patient. So this shows promise, but I have to sort of call your attention to some of these other plots here. So maybe for some of the other chromosomes, it's not quite so useful, because you can see that it's not quite so easily separated that, is this normal or is this too much? In this particular case, with these 18 samples that we gave them, they were able to separate that 9 cases had 3 copies of 21, 2 cases had 3 copies of 18, and 1 case had 3 copies of 13. But this is only 18 samples. And I think it's really important to remember that just because we can do this in 18 samples doesn't mean that we can do it blindly and get 10,000 patients and get it right every single time, which is what you want, right, in terms of the diagnosis for you. But I have to tell you, after this paper came out, we got calls every day, all the time, on whether they could do this. And I would encourage you to think about why you would want to do blood tests to have a result based on 18 samples. So when you read the literature, that's one thing. I don't think we're quite there yet. So I think I'm going to go through this real quickly because I want to show you the last few slides. So remember that first image I showed at the beginning? This is the way ultrasound used to look like on the left. This is the way ultrasound looks now. And we're so excited because we just got, in our unit here at Stanford, like 3 more machines. So all of our rooms have this capability of 3D, 4D. And the image quality is just amazing. So just a few words about 4D ultrasound. I know that it's very tempting to go and have your fetus's picture done at these malls. But we want to tell you that it's something we reserve really for special occasions. Maybe one photo we do give. I mean, I know it's a lot of fun, but we don't really know what the impact of ultrasound waves are on the fetus. And so we like to use it in a medically monitored setting. So most of our exam is done with 2D ultrasound, which is lower energy. And we only reserve our 3D for cases where we feel like it would give us more information, or at the very end we do play with it just a little bit, but not for very long. So here's an example of what we can see. Here's on 4D a hand. We can look at digital problems, the foot. You can look at each individual toe. So we've done that on people who've had previous history of a baby with an absent finger or extra toes. And facial features are also very... Let's just give you a couple of examples of cases that are interesting. 28-year-old Gravida 1, that means her first pregnancy, was referred from Modesto with brain and facial anomalies. The 2D ultrasound show holoprosencephaly, which is a brain that's completely missing a bunch of important things, and basically doesn't have the right division of the parts of the brain. Absent orbits, proboscis, which in the medical world we know means basically one prominent sort of nose with one eye. clenched hands, and 6 toes on each feet. The patient declined amniocentesis and wanted everything done because I don't think she really understood what some of these words meant, even though we taught her in Spanish and everything. So we did the 4D ultrasound, and we were able to show her what her baby's face looked like. And you can see here, there are no eyes. There's just some dimples where the orbits should be. And then this is the proboscis, which is the nose, which is on the forehead. So it's not something you'd want your baby to have. And she understood finally that it would look like this, and all those other words didn't matter. And she ended up deciding not to continue. So the second case where 4D made an ultrasound made an impact is a 25-year-old gravida 2 pair 1, who was referred from Modesto again with possible bilateral cleft lip and palate. And our ultrasound showed only a unilateral cleft lip, in other words, just on one side. And initially, a patient came in and had wanted to terminate. That was it. She had made up her mind. She couldn't possibly handle this cleft lip and had this horrible vision of what it would look like. So we did an ultrasound, a 4D ultrasound. You can see on this picture that there is a cleft. It's just on the left side of the face, and it's not very big. And she took a look at it, and she goes, "Oh, that looks like my other kid." And so I think given the fact that we can actually see the face and see that it's not such a scary thing, a cleft is very fixable, she continued her pregnancy. So that definitely changed her. And case 3, in terms of 4D ultrasound, the 21-year-old gravida 1 with Treacher-Collins syndrome, which is a syndrome where you're born with issues on your face where you look different. And I'll show you pictures. They have malar hypoplasia. They have a retrusive chin and jaw. They have overbite ear anomalies. But they have basically normal intelligence. But they just look different. It's also autosomal dominant, so you have a 50% risk chance of having a child affected. And it's variable how much penetrance or how much of these things will show up. So a 4D ultrasound really helped us in this case. So this is the patient up above. These are her features, her face. She's actually undergone a lot of surgery, so she looks really good. And this is her 4D ultrasound of her fetus. And just by doing this 4D, we could tell her that her fetus was affected. There's no genetic testing that would tell you for sure, or even if there was, we couldn't tell her exactly how the baby would look, but the 4D could. And you can see this is the baby afterwards. And there's really pretty good correlation with how the babies look in utero and ex utero. So let's go back to another section that I think was missing. The final part is MRI. So you may hear these words because we do have this modality, which is MRI, as a way of learning more about the fetus. So let's find a good example. So this is an example of a 2D ultrasound. This is not a very good one. This is on our old machines. You can not hardly see anything, but I happen to know that this baby has a bowel up in the chest, which is something you see when you have a defect in the diaphragm and it herniates up. So it's hard to see on 2D, but if you do an MRI, you can see here's the baby's head, and here's the body, and you can see the contrast here, or it's actually not contrast, but it's just the way the T1 imaging or weighting of the textures are. It can show you the bowel up here in the chest. And so that made the diagnosis as well. So if you have something like that, we might offer you an MRI. Here's another odd thing that showed up on ultrasound. There's something happening that was coming out of the baby's mouth. So here's an MRI, and you can see the head, and indeed there's a tumor in this particular, and this is what it looked like. It's called an epignathes. It's just a tumor which arises from that area. It's not malignant, but it is rather concerning because at time of delivery, it could obstruct and could be a problem with the airway. So this particular baby had a resection of that, and the airway was clear. But knowing about this ahead of time really helped us plan our delivery in a safe manner. So just to finish up, I just want to tell you that with these choices that we looked at initially, there's one more choice I mean, here we are. They're all summarized. Amniocentesis, CVS, first and second trimester screening, 2D ultrasound, MRI, and 3D, 4D ultrasound. And with all these modalities, we can really give you a lot of information about your fetus. But ultimately, the choice is yours. And part of our program is not just about diagnosing anomalies, but it's also about listening to you and educating you about what these mean and what's the right thing for the family. So here are some pictures of Down syndrome, and I just want you to understand that everybody has different preferences for what they want, and there are wonderful Down babies out there who are very happy and add a lot to everybody's lives. And so part of our counseling is also in what you want to do with the pregnancy once it's diagnosed, and there are a lot of resources for this common condition. They're listed here, and we can help you find more if you need. So just wanted to acknowledge that we have a terrific group of people that worked both the techs in ultrasound, the genetic counselors that work with us, Stephanie and Meg, who is the Center for Fetal Health, which means if you find something that's very out of the ordinary, they'll help lead you through the entire pregnancy and get to a good result with your baby, and the radiologists who do the MRI. So thank you for your time, and any questions?
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.